All right. So I have that it's 12:05. I think we should go ahead and get started. And again, my hope is that our colleagues will join us. I do want to confirm oh, here comes Dr. Holly. Okay, excellent. So I do want to confirm for folks that our time commitment today is until 3 p.m. We will stop promptly at 3 p.m. Hopefully I did that last time as well. I think I might have gone a minute over. Sorry about that. But we will stop promptly at 3 p.m. because I know you have things that you need to attend to. So again, thank you for being here for part 2. And what I would like to do is just take a moment. Oh, excellent. Here comes Zachary as well. Excellent. So, and that's perfectly okay. Again, I want to thank everybody for being early and for being on time as well. And let's hopefully continue that trend into our final 2 sessions. If somebody can remind me, just let me know using the chat again after you've typed your name. If you can see the slide, please type the letter Y in the chat. Not the word why are you asking us? But if you can see the slide, just type the letter Y for yes, I see the slide, Paul. So welcome back to Clinical Foundations II, Part 2, which is September 18th. And as I like to do in, and I believe I did this in part 1, but what I like to do for extra credit to start right off, if you know what the date is for part 3, type it into the chat right now. And you'll be doing me a favor by reminding me, although I think I'm pretty clear on, yes, it's tomorrow, the 19th. Absolutely, yes, tomorrow at noon to 3. Fantastic. And if you haven't had a chance to type that into the chat yet, please do. So just a reminder, folks, like I said last time, we're fortunate to be in a learning community conversation about this particular topic. What we talk about, what we focus on together, may not necessarily represent the official views of our funder. Yay, Deborah just joined us, so I think that means everybody's back, which is fantastic. Very glad about that. So as I said, what we talk about, what you bring to the table, what I bring to the table may not necessarily represent the official views of our funder, and that's perfectly okay. And we just want to acknowledge who we're very fortunate to have as a funder, and that because we are in a learning community conversation, we may not be reflecting quote unquote official views. As we talked about in session 1, our guideline about words and language as we interact with each other in this learning community, I'm going to ask that we go back to our commitment to intentionality in regard to that. Also, again, please be on camera. If for some reason you need to go off camera, don't worry about it. Please go ahead and do that. Just let me know you're going off camera and then please come back on. If you wouldn't mind remaining muted if you're not speaking, but as I said, I personally don't mind being interrupted, and I invite anyone to unmute or ask questions, make comments, share information as you see fit. But if you wouldn't mind remaining muted while while someone's talking or I'm sharing on something, it would be greatly appreciated, just so there's no background noise. Again, if for some reason a part of your technology fails or whatever, please participate with what you have. I would ask, if someone has the floor, that we not interrupt them. You can interrupt me, but please don't interrupt each other. Let people, offer them the respect of listening to what they're saying, whether you agree with it or not, and give them the respect and space to finish their point. Also, if you would continue, and again, people I thought modeled this quite effectively and generously in part 1, if you wouldn't mind speaking from the I believe this, I know this, I had this particular experience. So before we look at these 4 supervisory goals, I'm going to just stop sharing my screen for a moment and just ask, can everybody agree to those guidelines? as we agreed to last time. Yeah, you can wave, nod, and throw money. Notice nobody's still throwing money. That's perfectly okay. Excellent. Very good. Very good. Excellent. Very good. All right. So those are our guidelines. We're back. Those are our guidelines. And those will be our guidelines for part 3 and for part 4 as well. And thank you for agreeing to those. Now, before we go to those 4 supervisory goals, let me just ask, and this is before, I'm putting this before we go back to what I asked you to prepare, and I'll come to that in a moment. But any thoughts, any questions, any comments, unfinished business, or reactions from part 1 of our conversation? Any thoughts, any comments? Dr. Holly writes, prepare? What did he ask us to prepare? I could be reading too much of that. Yes, you are correct, Dr. Holly. You were to read. That was the only preparation. That was the only preparation. Don't panic. Do not panic. Chris, any thoughts? Any reactions? We'll come back to you, Margaret. So we're gonna jump to Chris. And Chris, only because you're right next to Margaret. I'm not necessarily calling you out, but I'm just curious. Any thoughts? Any reactions? Do you recall part 1 of our time together?
Part 1, from what I can recall, was like just becoming familiar. The part I took away from it was becoming familiar with like the different. I'm gonna call it. I don't know if we should call it TIP or TIP. I don't know. Does it matter?
Well, there's tips and there's taps. So,
so one of the things, yeah. So one of the things that I guess I just overlooked it, that my colleagues in our meeting here brought to it. It never occurred to me that 21 and then 21A, because when you read so much stuff, it like just blends together after a while. And then you don't like differentiate between what's for staff and what's for supervisors. Right. So it's like once you read so much information, it's like, okay, I'm reading through it. But then once you join something like this in this setting and you like, okay, well, this is for supervisors and it makes more sense as to why. And this is for the staff and it makes more sense as to why. Yeah. And then just I know it was our first meeting together, but just getting different of opinions on different views and things like that and just mixing everything together.
Fantastic. Thank you so much, Chris. Excellent. A great way to start us off. And, I think Margaret's unmuting. I think your mic might be working now, but hold your thought, Margaret. Don't lose it. But based on what Chris said, Chris, you prompt me to want to do like an impromptu sort of 21 is for who? Chris referenced 21 and 21A. So use the chat. The document that's 21 is for who? And type it into the chat. Tricia says for supervisors. Julia says for supervisees, for the clinicians. Okay. So, like Chris said, and Chris, I think you're absolutely right. When you're reading all this stuff, it can all start to blend together. Remember, folks, 21 is for the counselor. It's the tool that we as the supervisors use to look at the competencies of the counselor. 21A, A plus supervisors. 21A is the competencies of the supervisors. And these are tools that we can use. When we're supervising somebody else, we would use 21 because we're looking at their particular competencies. Now, if we're supervising the supervisor, we might use 21A. And I don't want to complicate things, but that's a possibility. Okay, but just so we're clear about who these tools are for. Okay, they're all a benefit, and like Chris said, you read them and having an opportunity to kind of bring them to life with other people makes them probably more useful in some ways. And again, everybody uses tools differently and learns differently. I share Chris's perspective. I benefit much more, Chris, from being in a learning community and like talking through the use of the tools. So
yeah, I do too, because it helps keep me accountable. Because I know if I'm like just told to read something and then I'm left to my own devices, I probably won't read it.
okay, well, Chris, I'm not going to ask you a follow-up question about pages 17 through 23, but we'll get to that later. But I won't be asking you. So Margaret, the floor is yours.
Do you still want me to refer to what I recall, or do you want me to talk a little bit about the different models of clinical supervision? What struck me with that?
Let's go with what you recall. We're not gonna move quite yet into the different types. And Margaret, yeah. do not think because you're talking now you've given up your place to talk about the models of clinical supervision.
No, I don't think that. I have a little bit of a different perspective, I guess, from a lot of the folks here.
Yeah.
Because I'm coming from a place with a doctorate of organizational psychology, and I'm an LCSW. And I haven't been in direct care with much clinical supervision above me for a very long time. So I've been a clinical supervisor for a very long time. Right. So a lot of this is, because of my education, I view what you use in direct care can apply very easily. And I have historically applied very one-to-one with clinical supervision.
Excellent. So Margaret, you're making that real connection between practice in terms of providing care and how that works into into supervision.
It's the same skill set. It's the same kind of foundation. And especially as we go into what we just read, that it's almost one-to-one, the different models and it's actually what led me to go for my doctorate was that I'm like, because I was spending so much time in supervision of direct care providers that I realized I'm like, it is the same thing, leading an organization, doing, mid-level management. It's all kind of a scalable solution, right? Yeah. So these models and these approaches work when you're working with people who you're supervising underneath you, and they work in direct care with clients or patients.
Fantastic. And Margaret, if you don't mind, you prompt me to want to ask you a particular quick follow-up question, if that would be okay.
Yeah.
So, and folks, we're still, Margaret is kind of helping us make the transition into what I asked all of us to read. But the floor is still open for you to talk about any thoughts or reactions to part one. But Margaret, you prompt me to want to ask you this question, which is, I share your perspective, and clearly the writing shares your perspective and your experience of the parallels between them. If you were going to draw a distinction, though,
boundaries.
Please, Margaret, please say that one more time.
It's boundaries. There is a lot further that you can go with clients and a lot more intimacy in that relationship than there is between supervisor and supervisee. That is a professional one, even though I still believe, even if you take it away from clinical supervision, that as my job in leadership, I will make sure, because work-life balance is so important, that I understand the challenges of each of the people that I'm supervising, but I will not go as far with the professionals that I'm supervising as very frequently people will do in discussing intimate issues and things like that.
Understood. And folks, underline what Margaret just said, because yes, and one of the most, two of the most outstanding examples, and there are others in the reading, but two where they talk about motivational interviewing and cognitive behavioral therapy. I mean, those are two very particular practice modalities, and they're applying them to the context of supervision. Mm-hmm. And again, I want to underline what Margaret said, because I think it's so critical. One, as the supervisor, supervisor must maintain the boundaries because you're not this employee's, you're not your supervisor's therapist or counselor.
However,
Margaret, did you want to add something?
Yeah, well, I do train literally everybody in my organizations, from operations staff, from janitorial staff, up to all the way up to direct care and managers. Everybody gets motivational interviewing training to know how to talk to the clients.
Yep.
And how to understand them and different approaches to just conversational, because everybody comes in. I run residential facilities. So everybody comes into contact with patients and clients, and it's really important that everybody understands how to talk to them. And I've just found that motivational interviewing training for everyone is super helpful.
Fantastic. Thank you, Margaret.
Yep.
Juliana, anything from part one? Anything unresolved? Any comment? Any reflection? Anything you remember from part one, in addition to pages 17 through 23?
So I may make myself a little unpopular here, but I really like agendas, and I'm all about treatment planning, and this is what we're going to work on in these days, and this is what we're going to work on in these days. And so I had looked at the overall agenda for session one, and we didn't get to very much of it. So for me, and then you assigned the some of the pages that I had thought we were going to be talking about, because models of supervision is one of the things that I'm really trying to nail down for myself. And so I was a little bit frustrated that we didn't really have a discussion about that, because that's something that I actually do need some additional insight, reflection, conversation, etc. And I'm not saying that what we did wasn't valuable, because I think it was. And so I think it was good to be talking about the top 21 and just some of the different perspectives that people have, and kind of get comfortable with this community. But I left kind of thinking, wow, how are we going to cram everything else into 3 more days? So that was, but again, that's just my brain is like, we like wants to tick the boxes off. And this was a lot more sort of organically developed, which was fine, but those are my thoughts.
Thank you. And I appreciate that. And, the other thing I really appreciate in what you're saying, Juliana, is you're really advocating for what you want from this. And I really want to underline something that you said, because I love the fact that you asked this question. And my sense is you may not be alone in asking this question, is how are we going to cram everything into the remaining time? The answer to that, folks, is we're not. We're not going to cram everything in at this particular time. So there are certain things that we are going to focus on, that we're going to emphasize. And as I said earlier, all of these resources, the participant workbook, the TAPS, the professional development plan. And again, I really appreciate what you're saying, Juliana, too, about how you like the idea of being able to check the box, being able to complete the form, being able to complete the task. I share that with you. We may approach it differently, but I share that satisfaction with you. But what I want to emphasize to all of you is that the content within this course is massive. And we are going to touch on various pieces of it in greater depth than other areas. And again, to Juliana's point, if there are things that you really, really, really feel like you want to explore in the learning community, bring them to the table. I welcome that, Juliana. And the other thing I want you to know, folks, is that it wouldn't be possible to cover all the content in this particular course unless we probably spent most of the time looking at the slides. And I'm pretty confident that each one of you in this learning community can read the slides. So, and again, don't misunderstand me. I value slides. They add a great deal of structure. But ultimately, the exploration is what will hopefully support what you're doing. And again, to Juliana's point, if you're not getting what you want, if there's something in particular that you're like, hey, I'd really like to dig a little deeper into that, put it on the table. And if we can do that, we certainly will. And if we can, let's hear from one additional person. Deborah, did you? Yeah, go ahead, Deborah, please.
Yes.
Go ahead.
Actually from
go ahead.
actually from part one, first class, I really got a lot. I was able to get an understanding about the development, the professional development plan. And I even talked to my supervisor about it. I mean, she doesn't have one, but she says, oh, if that's what you want, let's work on it, so
yeah.
Yeah. My question is the 21A, that's like 75 pages.
Yep.
And I didn't copy them. So I was trying to get an idea. Do you know what pages we're going to be working from, or?
Yeah, 21A, Deborah, is the competencies for supervisors.
Mm-hmm.
So what I'm going to suggest is at this particular moment, don't worry about that. And as long as you have the electronic version, you'll be fine.
Right. Okay. How about 21?
Yeah, 21A, you're going to want to have the electronic version of that too.
Okay. 21A, 21A.
Yeah.
Okay. So I just wanted to make sure if I needed to copy out anything or,
Just as long as you can read it either on paper or electronically, you're going to be fine.
Okay. All right. And our models and model 1, model 2. So we're going to be going over them. Like, I know the first one he said, the other sister said we didn't really touch on it. We was talking about other stuff. So I just made from the handbook. I just wanted to make sure I printed everything out. So
fantastic.
We had it. Okay.
Fantastic. You're prepared, Deborah.
Okay. I just wanted to make sure.
Excellent. Excellent. Okay. So any other burning thoughts or burning desires about last time? Anything else that you want to put on the table or any requests that you may have at this particular point?
Hey, good morning.
Good morning, Lourdes. Go ahead, please.
Well, this is a very, you know what I always say is I'm really a learner because I haven't been a supervisor and not that type. So let me clarify one thing that I would like to understand, as you already alluded to it, that a supervisor should not be a therapist. Now, as I've seen the models, plenty of them are, I guess, dealing into like CBT, MI, and interpersonal thing. So because in my experience as, I'm not long in this field, we don't talk about it. We all, when I come to a supervisor, we talk about clients. What is a problem with the client, like clinicals, but nonetheless, those ideas of like my personal development things, it's not really been raised a lot. Probably I did not raise it, or she did not raise it, or they did not raise it up for me. So what is now, I'm a little confused now with clinical supervision that engages clients, and then the personal development that we're trying to do, like for me as a supervisee, for example, as I supervise. So how does it sound? I'm so much, it's a little bit of confusing. I'm so sorry. That's my question.
That's okay. I think I understand your question, Lourdes, and let me try and say it back to you, and you tell me if I'm understanding it. And I want to comment on something that you said right at the very beginning, which is you said that supervisors shouldn't be therapists. Let me clarify that. Supervisors can be therapists, but they're not providing therapy to their supervisees. Okay? So that goes back to what Margaret was talking about in terms of the boundaries. Okay? So you may be trained as a therapist, you may be a clinician, provide, and hopefully you are providing clinical supervision. But again, because of the boundaries, you're not providing therapy to that particular supervisee. Okay. Now, Lourdes, you mentioned the CBT, you mentioned the MI, which are models of client sort of service provision that providers use to engage with clients. The literature is telling us, and Margaret also made this point, and we touched on it last time, that there's a parallel between what supervisors do with supervisees and what supervisees do with their clients. But the difference is the boundaries. That supervisors don't go into the same degree of depth that the clinician may go into with their client. So I hope that answers your question. Any thought or any reaction to that, Lourdes?
Absolutely, you got it. Okay, so yes, I know the roles. We have the roles to take at that moment without supervisee. Probably if I'm already a supervisor, so that's what could be, because we can all, as we're going into the modules, there's a real roles that I see, like a teacher, a coach, a consultant, a mentor, evaluator. So in other words, it could fit you as a supervisor, will fit to what the client, the supervisee needs. That's probably what it is at that moment. If he's ready, or the stages of change again, it comes into display again. So as you said last time, the capacity, I remember the word capacity. It helps. Thank you so much.
You're welcome. You're welcome. And Juliana wrote in the chat, and I think you're right. We don't treat our supervisees' mental health problems, but we do help them manage personal and professional issues and the blend of those. And it's probably fair to say, and Juliana, Margaret, tell me what you think about this. It's probably fair to say that the supervisor's not providing therapy, but the supervisory alliance can be therapeutic to the supervisee.
Absolutely. Especially in this industry where there is a lot of trauma associated with the environments we work in for employees. It can be, I guarantee most staff has been traumatized in some way. And that being able to have that validated and have those discussions can be quite therapeutic.
Yep. And again, folks, be very clear. It's therapeutic. It's not therapy. Yeah. And Juliana also notes, especially related to secondary trauma. Juliana, do you want to elaborate on that at all?
Yeah. So I'm actually out in New Mexico in a rural area that is the border town of a reservation land. Yeah. And there's so much trauma in the community, and it's such a unique community. And so even just trying to help the workforce manage the amount of stressors in their personal lives, as well as the kinds of trauma that they are encountering every single day, is one of the huge problems out here, is that trying to help clinicians take care of themselves, have good professional boundaries, be willing to work on their own stuff, and just not let their stuff interfere with the work that they're doing, or get so discouraged that they end up, using substances, getting, suicide or whatever.
Right. And we're talking about the workers, the supervisees. We're not talking about the clients.
Right. And, and again, they're from this community, and so even my non-clinician employees, it's like, gosh, they, every other weekend they have a funeral, or they have some crisis, or, auntie and uncle and children all want to move in with them. And, just, there's so many issues in a rural, impoverished area that I feel like if I can just get my supervisees to make healthy decisions for themselves, that's a huge step in terms of the kind of work that they're doing. And so, but you know, I try to really be clear about, I'm not treating your mental health issues. If you have mental health issues, you need to get a therapist for that. And navigating full-time work in this kind of work is really, really hard, and it burns people out and it messes people up.
Yeah.
And it's a really tough job. And my personal mission is to really empower clinicians to, like, you're allowed to have a thriving life and still work in this field. Like, you don't have to sacrifice your well-being and be like the martyr just to be a social worker or a substance abuse counselor or a therapist. Like, you should be able to like yourself and like your life and still have a full-time job in this.
So establishing that work-life balance. Yeah. And I want to touch on something that Juliana said. Trisha, did you want to say something? Go ahead, and then I'll touch on what Juliana said. Go ahead, Trisha.
I just wanted to ask, is it wrong? I know that a lot of times they don't look, they always ask for therapy. I know that my coworkers always ask for therapy because they know that I'm a therapist and where I am, because I'm not in a clinical setting at this present moment. They look for that guidance constantly. Is it wrong? I don't know, how should I address it to them politely without making it seem, because as I said, I'm not in a clinical setting, that, you know, thinking that they're crazy, but I feel that they need a higher level of care, mental health. They need to talk to someone.
And you're talking about a supervisee, correct?
Yes, this is a
okay.
supervisee.
Just want to be clear again. Go ahead.
Yes, and I feel like I always feel like I tell them, I know that you come to me with personal matters as we're talking, but I feel that you need a higher level of care, is per se. I don't know how to say it, like that, you know, they need mental health treatment, because I know in the jobs that we do, it's a lot of trauma, it's a lot of burnout, you know. So I'm just trying to say, so how do I address it to them that, you know, like, okay, as far as that, we have to consider talking about the work, and that moving forward, that you maybe want to talk to someone in the mental health profession, you know, talk to a therapist, you know.
Yep. And again, that's setting a boundary. Margaret just put in the chat, offering a referral for mental health services or to talk to an EAP, which is not you. And, you know, what you just said, Trisha, links completely to what Juliana just said. And, you know, Juliana, as you were speaking, you crystallized, at least for me, maybe for others as well, but you crystallized for me a real distinction that when we're supervising somebody, we're supervising them to the extent that they are well enough, professional enough, informed enough to do their job, not lead their life. Leading their life is where the referral to mental health therapy or to an EAP would be. So it's a real important distinction, I think, to make, that clinical supervision, certainly hopefully we're entering, and I think if Dr. Holly, as I say this, hopefully we're entering it with a person-centered perspective where we care, we genuinely care about the well-being of the supervisee. But our extent of support with them has limitations, and they may need, and I love the way you put it, Trisha, they may need a higher level of care, and that higher level of care would hopefully come from a mental health professional, even if you're a mental health professional, not you as their supervisor. And your work with them is to achieve a balance so they can be successful in their job, in their work. And who is it? Kristen wrote in the chat, you can't help others if you can't take care of yourself. That's very true. That's true on so many parallel process levels. It's absolutely true. And again, the role of the clinical supervisor is to make sure that this person is able to effectively, and as Juliana and others were talking about burnout and trauma and these other things, if a person doesn't have if a supervisee, let me be specific, if a supervisee does not have and cannot maintain a certain level of equilibrium, they are not going to be able to be functional. And supervision can support the development of a degree of equilibrium. And if the supervisee's needs exceed that in terms of the boundaries, it's appropriate as the clinical supervisor to make that referral, to assure that that person connects with an EAP. Juan, I saw that you talked a little bit in the chat about vicarious trauma. I wonder if you wanted to say anything about that. Excuse me, just 1 minute. I have to turn my my camera off for just 1 second. Go ahead, Juan.
So I was just saying, I've used my supervision to address my vicarious trauma when I deployed with the Army, but it was only for recognition. And if I needed to, if it impacted me and the care of my soldiers, then I addressed it with my own therapist, if that's the way I needed to go. But it was just like, these are some difficulties that I'm having, and I recognize that it is secondary trauma, but we didn't dive into like, okay, how else is this affecting you? Is this something from your childhood? Like, we didn't go into therapy. It was just like more recognition, and for my supervisor, situational awareness.
Understood. So yeah, we'll go to Zachary and then we'll go to Dr. Holly. Juan, thank you. Go ahead, Zachary, and then we'll go to Dr. Holly.
Yeah, so I think one of the question was like, how do you like bring it up in a way that's, not insulting? And I was looking through, I think, obviously we have to do, the homework where we, do the supervisory plan.
Yeah.
I think it was, competency 123.
Mm-hmm.
Which is, I think it's page 158 in the TAP 21. Like,
feel free, if you have that publication handy, to turn to that page. Go ahead, Zachary.
It says develop and use strategies to maintain one's physical and mental health. And if I would imagine, this is one of the things I'm sort of getting from like, the first session.
Yes.
It's like if you're noticing, the supervisee's bringing you like a bunch of personal stuff that kind of toes the line between therapy and supervision, be easy enough to like, to look at that particular competency and just develop a plan. Like, what are you doing to, so that this doesn't impact your work? It'd be like, a pretty easy way of learning how to, or of just bringing it up in a way that's not, God knows we don't want to like step on it. It's like right there for you. You don't have to like worry that, I'm saying it wrong. You just have them read it and say like, what can we do to, make these points sort of work for you?
Yeah. And Zachary, could you just repeat the page again?
Yes.
I just closed it. I think it was 158. No, it's 158.
158. Thank you, Juliana. Juliana put it right on the screen for us. 158. So I want to, Dr. Holly, don't lose your thought. I want to link what Zachary just said to what Juan just said, because Juan, you said something so insightful, because this can come up and will come up in clinical supervision. And again, Juan, your example is such a good one, because Juan brought it up as Juan, and you tell me if I'm capturing this correctly, okay? I don't want to misrepresent what you said. So tell me if I'm capturing it correctly. But Juan said he was having certain awarenesses as the supervisee. He brought them up in the supervision so that the supervisor would be situationally aware as it impacted his work with his supervisees. And the supervisor was able to hold and entertain that. And Juan did the personal work that he needed to do with his individual therapist, not with his supervisor. Did I get that right, Juan? Now, that is a great example, and it's very related to what Tricia said earlier, of where your supervisees will come to you, and they will, because of the nature of the work, because of the nature of their life experience, they will come to the table with these things. And we need to be able to maintain that boundaried line in addition to assuring that they're getting the support that they need from the proper resource. So just keeping that in mind. And Zachary's example of page 158 is a really great way to use the tool to sort of help develop a professional development plan. How wonderful for a supervisee to have the insight that Juan had, that his history was impacting his work. Clearly, he trusted his supervisor enough to tell his supervisor that. And his supervisor did not take him on as a personal client and was able to help him to get the support that he needed. Fantastic. So that's a wonderful real life example of some of the boundaries that we keep. Dr. Holly, thank you so much for your patience. And then I think Lourdes wanted to say something, and then Alexine. Go ahead, Dr. Holly.
So for me, I make sure that, and I think I mentioned this the last time when we all met, but I make sure that I look at my supervisee as a person and not just them a clinician within their role. So yeah, we do supervision, clinical administrative. However, I still find, coming from a personal centered lens, that I have to check in with the clinician. What that looks like, asking them, how are you feeling today? Did you eat lunch? Did you take a break? How was your weekend? Most of my supervisees have children or they're caretakers, so I asked about that. So for me, I do the small talk so that, again, it's a transition before we get into who they are as a clinician. If it does go towards something that is a little heavy, as I like to call it, where um, it is impacting who they are as a clinician, then I could suggest or maybe ask them if they have a therapist or EAP that they could tap into. But I feel like I have to tap into who they are as a person before, or just not always just have this lens like, okay, we're only here to talk about, you as a clinician, supervision, and let's just get to it. So for me, I have a more personal connection with my supervisees that have long expanded after they've left supervision or the agency. But I think that's just my approach and like who I am. And like I said, I know the boundary of, okay, this is going towards therapy. But to be honest, I have not really had that. I've been there when someone has lost a loved one or they're going through grief. Because again, if we don't tap, or if I don't tap into, I won't say we, if I don't tap into that, I already know it's going to spill over into in what they're doing for that day or that week, where they're not going to be fully present as a clinician.
Yep. And Dr. Holly, while you were saying that, I have to say, I again was thinking, you framed it this way, and I my sense of at least the little bit of time that I've had the opportunity to know you, you said, I do the small talk, but that's done in an authentic, empathic way because it builds rapport, folks. And it's the humanity that the worker is bringing to the work. And Dr. Holly, as you were saying it, I couldn't help but think, what a wonderful modeling example for hopefully what your clinicians are doing with their patients.
Exactly.
Because hopefully they're not sitting down with their patients and saying, okay, you have a substance use disorder. Let's get to work on fixing that.
Yeah.
And, that would be that approach may not work with a lot of people.
Yeah. And I just admire what Juan said in that he brought that into supervision, because I think that if somebody is comfortable enough with sharing that part of themselves with me, it also gives me insight as into how something may not connect for them that day. They may be struggling, or they may have had some type of issue with what they're balancing. So I have more insight in how to work with them now. So I
Yes.
appreciate what Juan said and how supervisees can bring that piece in, because sometimes as humans, I know I can make an assumption, but having that piece could lower or help me manage the assumption, what may be going on with that person personally or clinically.
Absolutely, Dr. Holly, because you're coming from an informed place. And I want to underline something Dr. Holly said, because I don't want it to get lost. Because this is a very nuanced and important way of thinking about clinical supervision. Dr. Holly, you said, and I think I heard you correctly, you said, and it's helpful for me to know that, because there's not really any way that can't impact how this person is going to proceed in their work. Because that's the thing that we are focusing on, folks. We want to meet that person, that supervisee, as a person, and we are doing our best to assure that they are going to be able to effectively do their work. And to Juliana's point, hopefully achieve a healthy work-life balance so that they don't become burned out, lost to the profession because they're too overwhelmed. Lourdes, and then Alexine, and then I'm going to share my screen with you. Go ahead.
Oh, I already lowered my hand, but just to reaffirm what Mr. Zachary said about the tab 21, 158 thing. It's because that's my problem a while ago, while you're talking about how we can bring it in a way that we're not kind of offending or making it negative to our supervisee. If we feel that there's something really not right or out of this situation, because if somebody's talking a lot of her life or his life and what's happening, and then we're not even focusing to the work that we really have to do. I mean, like clinical, I always say clinical. So that would be a dividing line or boundaries that we can say, but how can we do it? It's not clear. But this page that my colleague brought out is very important, so that I can see, okay, this is the guidelines. I feel like she's needing something out, not anymore like I could suggest or I could recommend here, or we can do it here. That she needed something outside so that the work will not be impacted, so that she can, actually I also see how my colleagues are so blessed with a lot of clinical people here. I'm so happy. But what I'm saying is, I did that with my clients. What I'm saying is, you cannot say, I'm seeing a client and you say, hey, substance use, what do you use? Why do you use it? You can't do that. You have to be engaged with their life, or what's going on, what's going on with you, etc. It's not you're trying to make this, in America you say, how are you? And then, hey, I'm fine. But it's nothing. It's not like that, just fine. You have to dig in a little bit with empathy, with how do you get this person talk to you in the real sense, that she's not afraid, she's not angry, whatever is happening. Like I have a client the other day, she doesn't want to talk to me, she got a lot of problem, and then at the end she said, I'm sorry, I was so rude a while ago, because at the end she's saying that she's not really getting into me just to get me, she really wanted to help. So thank you so much, and thank you, my colleagues. I'm learning a lot. So that's my question. After it's answered, and just like reiterating it, thank you for the time.
Understood. And, I want to underline something in terms of what you're saying too, is folks, keep in mind that clinical supervision it's a practice, it's an art. And it's an art in the moment with that supervisee. And our approach, it really is going to impact that. Again, if one of our supervisees is talking to us about something that's deeply personal, if they bring that to the table, hopefully, because we are practiced and we are hopefully modeling, we're not going to say, hold on a second, we need to turn to page 158, because we're hopefully going to want to be able to engage that person in an empathic, supportive way, and also still maintain the boundary and make the referral if a referral is needed. Alexine, the floor is yours.
I have a question because I have worked in an environment that was more academic. And a part of the academic program was that every supervisee was required to be in therapy while they were working. So it wasn't so much of a problem. I mean, we could recognize that there was an issue. We could do a one-way communication with the therapist of that individual just to make sure that that person is getting help. If something was recognized that needed to be tended to, we didn't ask for any feedback from the therapist, but just saying, hey, by the way, we want you to be aware of what we are noticing and seeing. So that makes that process easy in that environment. But when my question is, when you are in an agency or in a private practice where you may offer supervision, one of the things that I have done is laid out an expectation of what the supervisee can expect from me, and equally what I can expect from the supervisee. Yeah. So my question is, in an environment like of an agency or a private practice, could that be included in your agreement of expectations? And so that the groundwork is laid to say, if we notice that you might need some assistance while you're going, maybe struggling with something, that you would agree to consider. Is that appropriate?
It could be, and again, it depends on the setting, because you can't mandate people to therapy. I mean, I'm a social worker by training. I have often heard that, if you're providing direct services to people, you should be in some sort of therapy, because supervision is not therapy. It may be therapeutic, but it's not therapy. And hopefully a good, effective clinical supervisor will be very clear about that boundary and very clear about those limitations and expectations. So absolutely, depending on the program, depending on the agency, you could make that recommendation. Again, how enforceable is it? That doesn't change the work of the clinical supervisor, because it's possible that somebody could be seeing a therapist regularly, but what if they like Juliana more than their therapist? And they want Juliana to be their therapist. It's going to be incumbent upon Juliana to actually set that boundary, or to be clear with that person about taking advantage of their additional support. Because if you think about it, folks, and I'm curious, Juliana writes, I think it's an ethical issue. If your supervisee may be impaired, they shouldn't be practicing. Truly. Tricia writes, the problem I have seen all the time. Which problem is that, Tricia?
No, that the people I work with feel that I'm better than their therapist, and that's the issue. So, because I get to the core basis of things, and it's like, these are things that I tell them, have you talked about in therapy? Have you addressed these issues that, that you're having right now? No, but they're like, well, I'm just able to more open up and be more communicative with you than I can with my therapist. I just feel more comfortable with you.
Yeah. So. Yeah. And how wonderful is that? and the boundary still needs to be set and maintained. Still needs to be set and maintained. Margaret writes, we also have the advantage of seeing our supervisees in their environment. Absolutely. And many therapists generally don't. They get a secondary report of the situation. Understood, Juan. Not a problem. All right. So folks, I'm going to share my screen again. And I want to just touch on, and I'm very curious, these are 4 sort of what is framed as supervisory goals. And I'm very curious. They're numbered 1, 2, 3, and 4. But I'm curious from your perspective, which one of these to you individually, which number one of these to you is number 1? So they're numbered here: 1, promote professional growth; 2, promote welfare of clients; 3, monitor counselor performance; 4, empower counselor. But what I'm going to ask you to do is use the chat and type in, if you had to pick one of these as the priority, which one would you pick as the priority?
For a supervisor?
Yeah, your role as the supervisor, the goals of supervision. So which one of these would you pick as priority number 1? Go ahead, Ms. L. I see your hand is raised. So let's hope everybody got a way to weigh in on that.
I'm going between protect welfare of clients and then empowering the counselor, but you can't, you have to empower the counselor first in order to be able to, you know, let that, like ethical wise, right? Ethically, you empower the counselor because they're providing the direct service to the client, right? Direct care to clients. So again, I'm back and forth with those 2.
Okay. Ms. L, can I ask you a quick follow-up question? If this was a forced choice, you could not go back and forth between the 2. Which one would you're making an I statement here. Which one would you put as number 1?
I feel like I have to say 2. I don't know why I have to say 2.
Okay.
I'm with her on that.
No, I feel like it's kind of like I don't know why I feel like it's like a forced choice. I think that I really, like, in my mind, I would say empowering the counselor.
You're still straddling the boundary between the 2.
I am, and it's like, I don't know why. And maybe I'm overthinking it too much, or is anyone else like feeling that? Or I don't know.
Dr. Holly wants to jump in. She's been trying to jump in.
I'm struggling between 1 and 2 just because it depends on the supervisee. I can't say overall I'm coming in to do XYZ. Would I love to empower the supervisee? Sure, but they may be someone who's seasoned who may not need that. So for me, this feels forced, and my answer would come from a situational place than just who I am overall as a supervisor, because depending on what my supervisee needs. But since I have to choose, I'm going to go with 2.
Okay, you're going with 2. Now, I love that. I don't mean this in an unsupportive way, although I am not your therapist in this setting, but I don't mean this in a non-supportive way. I love the friction or the tension of having to choose one that you're experiencing. I really like that. And the question that I want to ask you is, why do you think I'm asking you to pick the one that you would prioritize within the context of this learning community conversation? Why do you think I'm asking you which one you would prioritize? Does anybody want to answer? Yeah, go ahead, Dr. Holly. Go ahead. Go ahead.
I'm sorry. I thought when you said you, I thought you were referring to me, but I apologize. I think you're asking because it will lead into what we had to read in regards to the type of supervisor we are, our style.
Style, yes, that's what I was thinking.
You were thinking style as well, Maisel. Okay,
Yes.
yeah. Gets definitely, Juliana. Hopefully, it's getting you thinking. And what I'm going to go out on a limb and say something here. But I'm going to read what Margaret wrote before I do. Margaret writes, at some point, we all find ourselves in the situation where the health of the counselor may negatively impact care. That's true, Margaret. And as the clinical supervisor, we have a responsibility there. We have a responsibility there. And Lourdes notes, because it is our business. Absolutely. It is the focus of why we're offering clinical supervision, to make sure that the clients get good care. And the way clients get good care is hopefully through good supervision and getting their needs met that they may have elsewhere. So I'm going to go out on a limb and say this. Depending on where, and it's very, these are 4 very simple kind of global things, but depending on where you land on these, they're going to impact how you provide clinical supervision. So it's an opportunity, yes, for us to start thinking about the models of supervision and what our style might be. And what I want to underline here, folks, I said this when we were together the first time, there are 23 of us in the learning community. No, 24 of us in the learning community, because I'm also a clinical supervisor. There are 24 of us in the learning community that are quote unquote clinical supervisors. We're thinking about being clinical supervisors. We are all, each one of us is going to have our own individual, unique model of providing clinical supervision. And hopefully, those are going to be models that are based on some of the models that we looked at. And they're also going to be based on our values and our beliefs as people and as providers, which are going to impact our style. And Dr. Holly, very early on in our first meeting, mentioned her orientation. And if anybody remembers what she said about her clinical supervisor orientation, type it in the chat. I remember it very distinctly because she elaborated on it. Yes, person-centered. It's a person-centered perspective. Yes, PC, person-centered. Absolutely. So again, part of this learning community conversation is for us to dig a little deep together about where are we coming from in regard to this? What kind of clinical supervisor are we, and what kind of clinical supervisor do we want to be? Because that's what 21A is for, our capacities as a supervisor. All right, having said that, I'm going to share my screen again. So keeping in mind, folks, that one of the things that we are always balancing in addition to clinical supervision and administrative supervision and evaluation is kind of a combination of these 2 things, but oftentimes what goes along with supervision is clinical as well as administrative. And I don't know about you, and I'm going to ask you to sort of put this in the chat. There's a whole learning activity that they focus on actually in module 1 in the manual about how you like to spend your time. But I'm gonna ask you to just vote in the chat, and you can vote by, would you rather be providing clinical supervision? And if you would, type a C in the chat, or would you rather be providing administrative supervision? You can put an A in the chat, or if you prefer to, if you like the idea of the blend, type a B in the chat for blend. And I'm very interested. Again, I'm seeing a lot of B's. I just saw a C. Excellent. So some people really like the blend. Yeah. Excellent. 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 And some people are saying C. I don't think I've seen anybody type just A. And that's neither here nor there. It would just be some people that is a particular area of interest for them. They very much enjoy the tasks and functions of administrative supervision. And be very clear, though, administrative supervision is not the same thing as clinical supervision. So these were some of the roles that people talked about. And what I'm going to ask you to think about here is, if you look at these roles, if these are the different roles that make up the job description of what a clinical supervisor is, my question to you is this, is if these are the roles, which one of these roles, and you can type it into the chat, and I'll leave the slide up so you can do this, but which one of these roles do you see for yourself as a growth opportunity? Which one of these roles do you think, as you understand them, and we haven't broken them down, we haven't, looked deeply, but just on the surface, which one of these roles do you see as a potential growth opportunity for you as a clinical supervisor? And just type it in the chat. 6 people have responded so far. Let's try and hear from everybody. Which one of these do you see? 12 people have responded. Which one of these do you see as a growth opportunity for you? An area that you'd like to enhance? Yeah, excellent. Somebody is interested in the BRB role. No, they just mean they'll be right back. Excellent. So coach, evaluator, consultant, excellent. Mentor, perfect. So keeping in mind that as a clinical supervisor, we may be called upon to fulfill these various roles. And what I'm going to ask you to consider, and this is what I'm going to ask you to think about for next time we are together, and this will start our sort of preliminary conversation tomorrow about this, but you identified a particular role that you see as a growth opportunity. Now, you may all recall, I'm going to stop sharing my screen, you may all recall 21A is the resource for supervisors. So what I'm going to ask everybody to do is take a little bit of time based on the role that you identified as a growth opportunity and see if there's any capacity in 21A that addresses that particular role. And be prepared tomorrow when you come back to share, oh, well, I looked at 21A and the capacity I identified was evaluator. And the 21A said this about evaluators, or 21A said zip about evaluators. So what I'd like you to do is I'd like you to use that resource, 21A, based on the role that you identified that you'd like to build capacity in. And I'd like to start our conversation next time from that particular place. Okay? Does anybody have any questions about what I'm asking you to prepare for next time? Is that fairly clear? Make sense? Okay. Fantastic. Good. And that's how we'll start off our conversation next time. I'm going to share my screen again. So, any reactions or any thoughts about this slide as we move into these different models of supervision? If you don't know where you're going, any road will take you there. That almost looks a little bit like my background, except there's a roadmap. Any thoughts or any reactions to that particular slide? Yeah, go ahead, Zachary.
Makes me think of actually, in my role as a clinician, I was running a CBT group at one point, and clients were taking very long during check-ins. So they're just rambling and, kind of talking about what's going on for them, to the point that we weren't getting to, some of the stuff. So, I had to, on, several occasions say, like, listen, I'm sorry to cut you off, but I'm going to have to cut you off because, if we don't learn these tools, we're not going to get better. It's like there are times, in place for like encounter groups, but unless you are, have some sort of framework, clients don't learn the skills that they need to stay sober. They could like vent and talk to friends, people in their support group. And, I think it's probably a very similar thing in supervision.
So Zachary, I don't want to put words in your mouth, but tell me if I frame it this way, and I love your practice example, is that having some sort of framework creates the ability to focus and move forward.
Yes. Yeah.
Fantastic. Fantastic. Lourdes, any thought, any reaction to that slide?
Yes, I do. But I put it in a way of practical life experience. I feel any road will bring you there. You don't know it, but because I think what motivates people, what is your values? What do you really want to happen? No matter, you don't know yet what it is, but you have that. You have the motivations, you have the vision, you want to do something. I think you don't know which road, but because of that's inside of you will eventually bring you there. That's my own take on this, but I'm so
understood. And one's passion, one's desire, one's motivation could help one to find a model or a structure that could give you even more power or make you more impactful as a supervisor. But you certainly do have to have passion, values, and beliefs that sort of move you in that direction. And it's probably fair to say, and this is related to what we were talking about earlier, is that depending on your values, your passion, and your belief, you're going to be more attracted to particular established models than others. You're going to be just gravitate to be more drawn to those particular models.
Right.
So to that end, I'm going to share my screen again. So we had these 4 broad types of models. And it's funny because if you look at bullet number 2, treatment-based, talk about parallel process there. So this idea that we can have models that focus specifically on competencies, also using treatment modalities, but in the context of supervision, developmental models, and integrated models. Now, I asked you to read pages 17 through 23 and be prepared to have a conversation about these different types of models. And the questions that I pose to you as you think about and we engage in this conversation is, what model type am I most attracted to? Again, based on what you read, and I have a personal disclosure to make about that in a moment. What about the model is attractive to you? And we'll hold off on number 3 for just a moment. So what I'm going to ask people to frame their remarks about is, what model type were you most attracted to based on what you read? And what was it about that model that was most attractive to you? So I'm going to stop sharing my screen and we're going to come back to the foundational beliefs in just a moment. Yeah, go ahead, Juan. Juan, we can't hear you. You're still muted.
Okay. Can you hear me?
Yeah.
So I appreciated, or I leaned more towards the integrated model.
Okay.
Because what stuck with me strongly was what Margaret said earlier. And the reason it resonated with me is because the way I am as a clinician kind of really directly translate into how I approach supervision in regards to my sophistication in speaking with the with either their client and or the supervisee. I still kind of use that same skill set. So I use a lot of MI, things of that nature. So that's where I really did enjoy more of I related more to the integrated model.
Fantastic. Thanks for starting us off.
Yep.
Other thoughts? And hopefully everybody got a chance to read those pages. Other models that stood out to you? Juliana, any thought? Was there a particular model that jumped out at you?
So no, because my problem is, so I read one and I'm like, oh yeah, that sounds great. That's totally me. And then I read the next one. I'm like, oh no, yeah, that sounds great. That's totally what
That's totally me too.
And then I read the next one. I'm like, oh no, that one's really great too. And so I mean, I guess that's an integrated model. And I still think it's probably valuable for me to have sort of a core model to work from. And I think I sort of tend towards like the developmental and competency based model, just because I'm naturally a teacher. And so I'm always teaching people and giving them information or examples or opportunities to try things. But I don't really know which one that fits in the most. So well, I'm kind of all over the map.
Actually, I was going to be facetious and say you're absolutely alone in that, which you are not. And it's funny that you frame it that way, because there's a word, Juliana, that really came to mind, and I identify with this, and this is, I guess, where I'll make my personal disclosure, is that what you're talking about is an eclectic model.
Yes.
A model that integrates pieces, and it's funny because in preparation for our conversation, I've read those pages a number of times over a number of years, but I thought, I asked the learning community to read those pages for our conversation, so I'm going to read those pages again. Now, I'm reading those pages again from where I sit today in my experience as a supervisor. And I had a very similar experience to Juliana, which is I was highlighting like, oh, I'm reading this model. And like, this really jumps out at me. This really jumps out at me. And they were from all different pieces. And to me, that's an eclectic model. That's where I'm developing my personal model of clinical supervision, like what Juan was talking about, what I bring to the model. And also, to Juliana's point, it's really helpful for me to know kind of where is that structural piece. And I love the fact that, Juliana, you identified that the competencies model and the developmental model kind of work for you because of a strength that you bring to supervision, which is the role of teacher. And it's interesting because as clinical supervisor, if you explore these models, you can say, well, where's the area of growth for me? And which model might support me growing in that particular area? And I'll give a concrete example for me, as I think about that, is the CBT model. That would be an area that I would need to grow in if I were going to be using that model exclusively in terms of giving assignments, helping the supervisee to come up with the tasks. So the idea, the competency base too, and I was thinking as I read through it, really lends itself really well to the use of our tool, 21, because that's looking at particular competencies. So Juliana, can I ask you just a quick follow-up question before we go to Lourdes? So if you had to, all those things that you identified, like, yeah, I identify with that, I identify with this. If you had to like shake it all up and kind of turn it into like one integrated sauce, what rises to the top for you as the highest priority? And you can pass if that's an unfair question. But I just wanted to throw that out to you because I think as having an eclectic model, one has to think about priorities and what the prioritization is. So does that resonate for you in any way, or is that an unfair question?
Yeah, well, I don't know that it's the wording of it is necessarily in these pages, but I think the thing that I tend to prioritize is like countertransference. So it's like the people's stuff. Like I was mentioning before, people bring their stuff into the room. If they're not aware that their stuff is in the room or they haven't dealt with their stuff in the room, that's going to potentially hurt a client. That's potentially going to get in the way of them doing everything else. And so I don't know if that's a treatment-based model or if that's a developmental, but that's sort of the micro piece to me that is at the surface.
Yep. And you know, for extra credit, and I'll just throw this out, this is for tomorrow, but for extra credit, in pages 17 through 23, countertransference is mentioned. And I know it's mentioned because I highlighted it. So for extra credit, let's see who can identify which of the models countertransference is actually listed. It's actually laid out. And Juliana, thank you so much for being willing to kind of mix it all up and identify that, because that is one of the strengths and the unique elements that Juliana will bring to supervision. She's aware of the dynamic of countertransference. She's aware of the dynamic impacting. Melissa, don't reveal it yet. Let's see if anybody else can. But don't read what Melissa wrote in the chat. It's all right. It's yes.
You said extra credit, so
extra credit. Extra credit.
I jumped on extra credit.
Fantastic. I love it. I love it when people jump on extra credit. We'll have to come up with something else, Melissa, before the end of today. But again, folks, the fact that we go through this process of looking at these models, looking at points of resonance, and then building our own unique and individual model of clinical supervision. Lourdes, I'm going to give you the floor, and then I'm going to go back to the slides.
Oh, okay. So, sure. I just want to resonate what you said about the eclectic type of counseling or supervision. It's because I believe if you talk about the person-centered, which is among them, you know, we as supervisor, I believe we should be flexible, very much flexible and adaptable to what it is happening there. But I'm also reading about the integrated models, which I believe, you know, the integration of this also will come into the point of, are this supervisee ready for this? Is he ready? Is this a chance for him for her to change, or what are we doing with this therapeutic relationship? So I believe, you know, we are always our priority is what their priority. In other words, my priority should be what their priority, like we are doing with our clients. Our priority must be what client's priority is. Not 10 problems there. What is the priority there with the client? Not, I always say not my priority, but you know, I know that a lot of my colleagues will not believe, you know, agree that, because what about you? You're not developing your personal growth. You're always saying it's a balance, you know. So I don't know what I feel, because I'm not there yet. It could be always so that I have an anchor. It's always probably be what the clients need as what my supervisee needs. Then I could probably adjust myself. You know, in the future, I could do that while I'm learning, but right at the moment, here and now, I'm focusing on what she needs. Probably that's the model I would like to, that could be integrated with all these things, so that I would learn in the future, that I will learn through this clinical practice what should be balanced and to me too. Thank you.
Absolutely. Thank you, Lourdes. And you're underlining something that I think is a very critical component to consider. And I'm thinking of Dr. Holly, I'm thinking of Juliana as I say this, which is that we can identify what models are resonant for us or what model resonates for us. And to Lourdes' point, we need to be able to be flexible and adjust based on the supervisee sitting in front of us. And I'll give a concrete example. I mentioned that CBT might be a model that might be, it is a growth opportunity for me if I were going to integrate that into a supervisory structure. Well, what if I have a supervisee that the way they learn, the way they focus, that having a task, having something, it is incumbent upon me as the supervisor to build my capacities to meet the needs of my supervisees. So one can't sit with the luxury of I'm this kind of supervisor, because you want to be able to be effective with every supervisee. I mean, and to varying degrees, some supervisees you're probably going to be more effective with than others. But you want to be able to be effective with every supervisee that you have the opportunity to be providing supervision to. And to Lourdes's, again, insightful point, if your supervisees are providing services to clients and all they know is cognitive behavioral therapy, but they don't understand like maybe concepts of motivational interviewing, they need to build their capacities to better engage and serve their clients as well. So supervisors there's a parallel process there as well. And again, I love the word that you used, Lourdes, flexible and the ability to adjust. We need to be able to grow our eclectic model. Yes, we have particular orientations. We have particular leanings toward particular models. But that's why exploring these models within this community can be helpful, because we're putting them on the table. Samantha, I want to give you the floor and see if there's anything you want to add as well at this particular point.
Sure. So I was more of like the eclectic as well, because I was the same as Juliana. I went through and I'm like, yeah, I know MI, I know these, I know that. And then I got towards like the integrated and I'm like, well, this is what I use on like my clients and patients. So if I'm knowledgeable in that, why not use it towards supervisees? Like they went through like the stages of change and I'm like, I didn't even think about using that towards a supervisee, because I'm like, my brain is, pre-contemplation of like substance use, like, oh, I don't need help, I don't need whatever, but I never thought to put that towards someone I'm looking after, if you will. So that opened my eyes a lot.
Yeah, and I loved seeing that one there too, and being reminded of that one, because what a great opportunity. What if let's say I have the opportunity, let's say Brittany is my supervisee, and I have the great opportunity to see Brittany engage in a conversation with one of her clients. And I observe something and I kind of bring it up to her in supervision, and she's like, no, that's not a problem at all. I don't see any problem with that. Helping somebody to explore that in supervision and thinking about it from a trans-theoretical perspective or stages of change model can be really helpful. All of these are lenses as to how to look at the interaction between the supervisor and the supervisee. Samantha, thanks for putting that on the table. All right, I'm going to share my screen again. Now, I think what I'm going to do, let me check the time here. All right. Well, let's do this. I'm very curious to your thoughts and your reactions. We're going to come back to this after the break, but I'm very curious as to your reactions to these bullet points, that these characteristics are sort of emblematic of an effective supervisory alliance. High level of trust, increased self-efficacy, increased comfort, higher level of motivation for growth, greater satisfaction with counselor role, improved counseling performance. Do you think there's anything missing here? How would you know if you have an effective supervisory alliance? What do you think about that, folks? How would you know if you, Ruby, any thoughts? How would you know if you have an effective supervisory alliance?
I would say the work that the counselor is producing,
okay.
The work, our conversations, and just looking to see the healthiness, if there's the healthiness of the counselor,
okay,
and just the work itself, the work with the client, the work with the treatment plans, the work overall.
Yep. Okay. So the work, and you also mentioned sort of the health of the
yes.
work.
Yes.
Okay. Excellent. Thank you. Brittany writes, the work plus the trust. Brittany, can you say a little more about that? What do you mean? How would I know if there was trust?
So I was just saying, I definitely agree with what she was saying as far as the work, but also with the trust, meaning maybe they're coming to me with something that's embarrassing, or something that they're really uncomfortable sharing, or something maybe they screwed up really big, because those would be things that might be hard to tell a supervisor. So those would be signs indicative that they trust you, because that makes it much easier to be effective in the relationship.
Yeah, and Brittany, I want to link what you just said with what Juan wrote in the chat, the supervisees being vulnerable. So they're willing to take risks as well as be vulnerable. Letitia writes, supervisee performance, morale, impact on clients. Okay. Juliana writes, accepts feedback. Juliana, can you say a little more about that?
Yeah, I think it goes along with what Juan said about the vulnerability, willingness to be vulnerable, and then also, just that openness to correction or to feedback, or to, to receive constructive criticism, to receive something that may not feel very good, shows a degree of trust and alliance there. And that just comes from a bad experience. Right? When I've had supervisees who don't take it very well when I have something to offer them, that tells me a little bit of something about our alliance.
Mm-hmm. Mm-hmm. Yeah. So the lack of receptivity.
Yeah.
And I want to distinguish something here, because it's possible, and tell me if you agree with this or not, Juliana, but it's possible that we might offer something in supervision and the person might not agree with us. And depending on how they disagree might be an indication of supervisory alliance or not. Juliana, are you okay with me making that distinction?
Yeah.
Because I could actually see that as like a high degree of supervisory alliance if I say to Tricia, I noticed this particular thing. I wonder what your thoughts are. I wonder what your take is on that. And Tricia says, that's not at all my experience. In fact, I don't see it that way at all. In fact, this is my understanding of it. That Tricia would feel comfortable enough to feel like just because I'm her supervisor, she didn't have to agree with my take. Absolutely. Kristen writes, the willingness of the supervisee coming to you with a problem. And yeah, and similar to what Brittany was saying, like they may have screwed up really big time. And they come to you and let you know that. Letitia, can you say a little more what you mean by morale? What do you because that word gets thrown around a lot, and I'm very curious as to what your thought is about that. What do you mean by morale?
I think just overall within the organization that you work for, the people that you are supervising, which usually is more than one person, if you're making an impact on more than just one, if 3 or 4 people have maintained their employment with you, with the organization, and seem to be happy, if you're happy at work and you're happy doing what you're doing, I feel like it really impacts the clients and the work that they're doing. So if they're happy at work, I feel like a supervisor plays a huge role in that. So
understood. In terms of that, you're helping them to feel good about the work they're doing and feeling good about the process that they're in as they're interacting in supervision.
by building like the confidence within whatever assignments they're working on, if you are helping them with their confidence and just overall healthiness as a whole, I feel like it makes a huge difference.
Fantastic. Fantastic. Thanks, Juliana. Absolutely. So I'm going to share my screen again. So in addition to everything we talked about, these can also, as we said earlier, can be indicators of an effective supervisory alliance. And more than the specifics at this particular point, the thing that I'd like you to underline is asking yourself the question, how effective is this supervisory alliance? How effective is it? And of course, that's going to be a unique question for each supervisee, and you're going to get a unique answer for each supervisee. So these tips, these are just basically some tips that are offered that are part of the resource of this idea of establishing mutuality and collaboration and, rapport. I'm also thinking of Dr. Holly in terms of person-centered. I'm also thinking about the kind of relationship we build with supervisees. I'm very curious what your thoughts are about the use of self-disclosure to foster openness, honesty, and willingness to admit mistakes. And I want to underline here, what this tip, I believe, is referring to is our willingness to use self-disclosure to foster openness, honesty, and willingness to admit mistakes. Our mistakes, not necessarily their mistakes. We talked about that before. But I'm curious as to what your thoughts are about that, folks. The idea of supervisor self-disclosure. Barrera writes, I think when the supervisees being open about their abilities and admitting their weaknesses to the supervisors. Yes, and that would be a sign of effective supervisory alliance. Any thoughts or reactions about supervisor self-disclosure? Yeah, go ahead, Dr. Holly. No, you were just scratching.
I didn't have my hair. I was just scratching things.
Okay. All right. Brittany, did you want to say something?
Which Brittany?
Brittany D.
I sort of had my hand up before Dr.
I sensed sort of. Yeah.
Yeah. I was just gonna say, like, I feel like it can go either way. Just like using self-disclosure in the therapeutic relationship. I think it has to be important, not so much on the situation, like what happened when you're self-disclosing, more so as like what you did about it, the repair that you did, focusing on that end of it. So yes, self-disclosing, being relatable, showing you're human too, showing, whatever level of progress is possible, but focusing really more on like the end of it as, and this is how, I did it, because sometimes giving that feedback is very helpful.
Mm-hmm. 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 Yeah. And Juan is also noting, as long as it's about the supervisee, people are also talking about, I think it's about being relatable in the moment. Brittany, you mentioned that. And the purpose of the disclosure, just like it would be, Brittany Landa, anything you would add in regard to it?
No, just the parallel. I keep thinking about the parallel between like supervision with, I mean, not supervision, like working with your client. Like, is this going to move the relationship forward? Like, if the client is hesitant or something to disclose about something, and you kind of like put a little bit of self-disclosure, it might make them be more open. So I think in the same respect, you can do that with your supervisee. Like, it can help foster more openness and trust.
Beautiful, beautiful. Kristen writes, if the supervisor has been in a similar situation in the work environment and the solution you worked on. Yeah. I'll just add one personal example. I don't think I mentioned this when we first started working together, but I'm a social worker by training, and my area of focus was group facilitation when I was in social work school. So I develop and facilitate, and I also do a lot of teaching and training around group development and group facilitation. And a personal disclosure that I make sometimes is about a particular situation when I was learning, and from a developmental model of supervision, and that's the angle or the lens that I'm coming from as I share this. Sometimes when I'm working with new group workers, I will share this story, and I don't need to tell you the story necessarily, but I share the story, and it's a story where, like, I didn't fix the situation, I didn't solve the problem, and the issue went unaddressed. So what I actually share, and I frame it this way, is where I failed. And it was because of where I was in my process. And I think, to Brittany's point, the way that it's an appropriate disclosure is that reflection on the failure improved my practice going forward. So that's the purpose of it. It can help the supervisees function more effectively. Yeah, absolutely. It can. It can help them. And I think it can also help them to realize that doing the work that providers do is a developmental process. We get better at it the more we focus on it, the more. And it's a parallel process with supervision as well. So again, as Brittany Landa was saying, this idea of thinking about that parallel process, self-disclosure, supervisory self-disclosure can be very helpful in dismantling what can be an ineffective hierarchy. And we always want to be intentional about it. We want to be clear as to why we might or might not be doing it. And again, the last bullet, I'm very curious if you were going to link this include supervisee in setting goals, planning, and evaluation process. Is there any particular developmental model or any particular model of supervision from what you read on pages 17 through 23? Is there any particular model of supervision that you would link to this particular tip? Include supervisee in setting goals, planning, and evaluation process. Is there a particular model or lens of clinical supervision from the reading that you would practically link that bullet to? And if there is, you can unmute and share it, or you can put it in the chat. Zachary says solution-oriented, ? Charles says blended. Melissa says blended. Charles, would you be willing to unmute and say a little bit about why you would link that to the blended model. And you can pass if you don't want to, but if you'd be willing to, that would
No, not me.
Don't pick me.
No, I think it's the blended model for me encompasses a lot of the pieces that some of the other models have. And it is very, it's centered. It's also client-centered, has individualized approach to it. And I kind of think of it, it is based on what the supervisee needs, right? And being able to pick and choose what works for the supervisee. And that's why we talked about individualized goals and settings, because that is what the supervisee needs at the time, and they set the pace, what's in session. So
fantastic. Thank you for your elaboration and for justifying the link to it. Fantastic. Yeah, go ahead, Deborah. Go ahead.
I would say person-centered. And that's because I believe in setting goals. And I believe in that once the person set their goals and they start working on their goals, it's a process of going back and to see the progress they have made.
Mm-hmm.
So for me, it's person-centered model of supervision.
Excellent. And again, person-centered because they're collaboratively setting the goals, yes, and then they're reflecting on those goals.
And being able to look and see the progress they have made.
Fantastic. Fantastic. So folks, before we take our 15-minute break, I'm going to ask everybody to use the chat. And I'm going to ask a question, and I don't want you to think too much about the answer that you type, but I'm just going to ask you to reflect on this for a minute. Because within the context of the learning community, we've talked a little bit about these models of clinical supervision. We've talked about their resonance, and we've talked about their utility. And the question that I'm going to ask you to focus on, and again, don't think about it too much, just let whatever comes up for you and just put it in the chat. And we'll look at what people put in the chat, and then we'll take our 15-minute break in just a moment or two. But what I'm going to ask you to think about is, based on our learning community conversation about these models of supervision, because there are a number of them, what do you take away that will be useful to you as a clinical supervisor? What do you take away from our discussion and our reflection on these various models that'll be useful to you? So you're making an I statement here. That will be useful to you as a clinical supervisor, either into the clinical supervision work you're already doing or the work that you will begin to do. So what do you take away from our group exploration, our conversation, that will be useful to you? Mm-hmm. And just take Brittany, thank you. Brittany's the first one, and just feel free to read what people are putting in the chat. Mm-hmm. You know, Samantha, I really am interested in the language that you put in there. And I want to read what you said. You said that there's always room to grow to be able to provide better services to the supervisees, and talk about that parallel process. Because if we're, as clinical supervisors, providing better, more effective, responsive services to supervisees, again, within the boundaries of clinical supervision, providers are going to be able to do the same thing with their clients. And again, just take a moment to read what people are putting in the chat. Mm-hmm. 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 Yeah. Yep. That clinical supervision can also focus on growth, not just strengths. because we can identify growth opportunities. To be flexible and adjust, reflection on failure. Heather, I'm just going to read, I'm reading all of them, but I want to read what you wrote. Dr. Holly, you're unmuted. Did you want to say something? No? Okay, just checking. When I see people unmute, I usually ask that. Heather writes, I feel that one model will not fit all, that supervision is something that will always be evolving. Wow. Folks, please underline what Heather wrote there. It's something that will always be evolving. And again, hopefully it can evolve on sort of knowledge and understanding and exploration of existing models of supervision. So we can be very clear. Thanks, Eunice. Yep, fantastic. All right. So folks, what I'm going to suggest that we do now is let's take our 15-minute break. We will come back, and then I have a particular scenario I'd like us to look at from a supervisory perspective. And the other thing that you can be thinking about is there a particular lens or model that you might apply to this? So let's take 15 minutes, and I will see you in 15 minutes. Thank you very much. My goodness, folks, I hope you had a good break. So I'm going to ask you to prepare, remember, for tomorrow, I'm going to ask you to prepare. You identified a particular area of growth for yourself. And what I'm going to ask you to do is review 52A and see if you find a particular capacity that relates to that in terms of your area of growth, or let us know that there was zero reference to that area of growth. Yeah, 52, I'm sorry, 21A, thank you. Yes, now I'm getting, yes, 21A, yeah, absolutely, 21A, thank you. I don't know why I wrote down 52. Charles asked a question about 52. Yes, it's 21A. And I'm asking you to be prepared for that conversation when we start tomorrow.
Just a quick question. What page in 21A?
Okay, that's what you're going to have to figure out.
Oh my gosh.
because can I give you a little would it be okay if I made a suggestion?
Sure.
Use the index.
Okay.
Use the index. Because part of what I hope that people will walk away with from this particular learning community conversation, some people described very vividly having bad reactions to these tools, where somebody like came in and just dropped the thing on your desk and said, pick one, let's talk about it. My hope is that when it's all said and done, and we've had our time together, that you will have a different relationship to these particular resources, that you'll actually experience them as resources. So I'm going to ask you to just make your best effort. You identified a particular area of growth for yourself in terms of your growth as a clinical supervisor. And I'm going to ask you to review. You can use the index to help you locate that capacity. Now, it is possible that there may not be something in regard to it. But what I'm going to ask you to do is make your best case guess using that resource to identify a particular capacity. And we'll start our conversation next time in regard to that. Barrera, does that answer your question? Or do you have a follow-up question or comment in regard to that?
No, that answered my question. Just give me a bit more digging.
Yes, I am going to invite you to dig a bit. Yes, thank you.
Okay.
Yes. Yes, 21A. All right. Understood, Julie. Thanks for letting me know. You're having storms too. Okay. All right. So folks, what I'm going to ask all of us to consider at this particular point in the remaining time that we have, because I would like to leave a little bit of time at the end if possible, and hopefully my connection will remain, but leave a little bit of time at the end maybe to reflect a little bit on our conversation today. Not too much time, but maybe a little bit. But what I'm going to ask you to do is put your clinical supervisor hat on, whether you are currently a clinical supervisor or not. I think the larger balance of people in our learning community are already supervisors, and that's great. And if you're not already a supervisor, that's okay too. Just put that hat on as best you can at this particular point. I'm going to share my screen again, and we're going to look at the slides. And I want to take us to a particular scenario that I'd like you to look at. Now, actually, before we do that, I do want to just touch on a couple of other tips that are provided in the slides. And one of them here is about managing boundaries, and dual relationships can be a part of that, but managing boundaries. And we talked about earlier that one of the major distinctions in clinical supervision is making sure that we are clear about the boundaries. The purpose of the clinical supervision is to help the person to be able to effectively do their job, not necessarily for them to have a successful and fulfilling life. Again, their personal work is to develop that work-life balance. And we need to be very clear. And Trisha, I'm thinking of you when I say this, as people come to you and say, like, I'd much rather talk to Trisha than to talk to my my therapist. But again, we want to be very clear about these boundaries. And I'm thinking of something, and I think it was Alexine who said this. I'm not sure if it was you, Alexine, but the idea of establishing agreements about how to proceed, because you had talked about, I think it was you who had talked about how there can be, we can talk about, like, is the agreement that you're going to make sure that you have access to individual therapy, or that you're engaging in individual therapy, so that these things are things that we can kind of put into place at the beginning of the conversation, if that's possible. We can't mandate that supervisees are going to go to therapy. They may not have access. They may not have the resources to do that. But again, we may need to identify that they need to access. And I'm going to use the words, I can't remember exactly who said this. Please identify yourself in the chat. But one of our colleagues said today, they might need a higher level of care. They may need actually care, not supervision. Trisha, was that you? Did you say that? Yeah. Yeah. And
yes, I did.
Okay, excellent. As I said, it reminded me of you. Okay.
Hi, Paul.
Yeah, go ahead, Eunice. Go ahead.
When you have a chance, can you talk a little bit more about talk openly about hierarchy of power and the means available to resolve problems? Is that what you was just talking about, referencing if they need a higher level of care?
No, that I think would be something very different. What I would talk about, the hierarchy of power, and let's really put it kind of on the table, which is there's a supervisor and a supervisee. And that inherently there's a power differential. And let's be very clear about that. That power differential can be, you may be, Juan may be my supervisor, and he's doing my performance evaluation, which is connected to my salary, and talk about like a power differential there. So we want to acknowledge that that power differential is there, and we don't necessarily want it to be a barrier to effective supervision. But I think we have to acknowledge that it is there, because there is a supervisor and there is a supervisee. Now, I'm thinking of Dr. Holly as I say this. Dr. Holly, the orientation that she identified in day one is a very person-centered orientation, meaning, and Dr. Holly, if I'm mischaracterizing what you said, please clarify for me. But my sense is, if I were Dr. Holly's supervisor, she would invite me to be part of my professional growth. She would invite me to help solve problems. Is that fair, Dr. Holly?
Yeah, I'm never coming in and saying like I'm, the expert on the clinician's caseload, their relationship they have with their clients, but I am there to work collaboratively in problem solving, sharing and advising on tips, whether it's going to therapy or approach that they could possibly need. So it's very, very collaborative.
Yep. So I can have that very collaborative relationship with Dr. Holly, and Dr. Holly is still my supervisor. And Dr. Holly is still the person who signs off on my time card. And Dr. Holly is the person who completes my performance evaluation. So that's, Eunice, that's what we're really talking about in terms of the hierarchical realities. And again, we can position ourselves in, and Dr. Holly is, responsible for carrying out the mandates of the organization, which she's going to help me as the supervisee to successfully complete as well. Does anybody else want to add anything or underline anything about this hierarchical piece that Eunice brought up? Because very good point, Eunice. Any other thoughts or anything that anybody would add?
I had a question.
Yeah, go ahead, Dr. Holly, please.
It wasn't more so about the hierarchy, but I don't know if we're going to get to this, and we may not because we're done at 3. But I haven't heard anything brought up around cultural. I don't like to use the competence, but inclusivity. Anything around the person's or the supervisee's culture or the identities. I'm not sure if we'll get to that in day 3 or whatever the case may be, but I haven't heard anything around that just yet.
Yeah, and Dr. Holly makes a great point, and let's talk about supervisory capacities or competencies, because being able to work in cross-cultural supervisory alliances will be critical. And I'll give a concrete example. And Dr. Holly, if it's okay, do you mind if I refer to you as if you were my supervisee?
Yeah.
So if I had the opportunity to be Dr. Holly's supervisor, well, Dr. Holly and I, at least from a visual perspective, we're from different racial groups. And we may share a racial group, but culturally, we present very differently. And it would be incumbent upon me as the supervisor to have awareness, respect, be open to learning, be open to conversation about how cultural differences may or may not be part of our supervisory conversation. And I will throw out, even if I were providing supervision, let's say to somebody who identified as a white male, I still would want to have awareness around cultural competence, cultural humility, and cultural awareness. Dr. Holly, is there anything that you would add to that at this point?
No, I think you've recognized our differences, which is important because we may have a different perspective based on our differences, which is something that should be at least addressed and talked about. So no.
Right. And I love the way Dr. Holly put that, because something that could be addressed and talked about, and let me underline something here. Something not ignored or avoided. We would ignore and avoid any of those differences at our peril as clinical supervisors. So just keeping that in mind. Barrera, you have your hand up. Go ahead, please.
Berita.
Barita. Oh, sorry.
That's okay. Just want to throw in a bit with this cultural thing.
Yeah, please do.
For instance, I'm an African American, and I'm Black African American from the Caribbean. And oftentimes I've seen in my setting that because somebody is of my ethnicity and comes in, they take it for granted that I should be able to talk to that person and counsel that person because the person may be from the Caribbean as well. But not knowing that although it's a Caribbean country, it's different culture in everywhere. People have different behaviors. Even in the same culture, there are different subcultures. And you don't take it for granted that because I am from that ethnicity, then I can deal with a person, because we are totally different with different beliefs, different cultural practices. Yes. Even sometimes the way people eat, there are different meals that people provide differently. And, so that is something so important, that not because we are of the same origin, and you must think that I can really level with you or relate to you, because you can be something totally different. Absolutely. So that is very important, that as clinicians, we are aware, we are culturally competent, that we can able to deal with people, not taking for face God because I'm from here, you're from there. We could be from the same household, but we have different values.
Yeah.
So
we're not a monolithic people. Like nobody who shares the same racial identity is the monolithic type of people. And I do a supervisor training on that too. Just because we're all Black or we're all white or all Hispanic, Latina, it doesn't mean that we grew up the same.
we have the
right.
same.
Exactly.
No. And thank you both. And I don't want to derail us, because this training is not, cultural competency journeys toward effective practice, which is another training. But I do want to ask this question because, again, Dr. Holly, thank you for bringing this up. And 21A, and I think I'm speaking very clearly here, 21A as well as 21, both address cultural components. But the question that I want to ask everybody at this particular point, and you can use the chat, is if you're familiar with this, type a Y in the chat. If it's new to you, type an N. Who here is familiar with the framework of cultural humility? If you're familiar with that, type an F. Yeah, Juliana, you're familiar with it? Okay. If you were going to give kind of like a nutshell of a definition of what cultural humility is, what would you throw out on the table? And then Lourdes, I see your hand. It will come to you. But what would you throw out on the table, Juliana?
Don't assume you know anything about anything. And
yes.
And don't assume that your way of doing things is better or works for anybody else, or that what somebody is doing just because you're not familiar with it isn't appropriate.
Fantastic. And I'm going to add one thing, and Juliana, tell me if you're okay with this in terms of if it fits with your understanding. I can only be an expert in one culture, and that's my own. So I will always be in a position of, when I'm speaking to somebody that looks like me or doesn't look like me, that was born in the same town I was in or wasn't born in the same town, or, eats oatmeal for breakfast or doesn't eat oatmeal for breakfast, I'm always going to be in the position of learning about their culture and trying to understand the situation from their perspective. Juliana, I see you nodding your head, so you're okay with me adding that? Okay. Lourdes, did you want to comment on this? Or were you just Or were you just voting that you were familiar with?
Yes,
that
I'm
you
just familiar with, but both of you are very good with that. It's an opportunity to learn, as you already said that. I'm just reiterating, to learn their culture, and because they are the expert of their culture, and I think it's a good thing to know. Very well taken. Thank you.
Yes, thank you. And to add something to both what you and Juliana are saying, the thing I want you to keep in mind that cultural humility, folks, is suggesting that it's a lifelong opportunity to learn. That it's truly a value and a perspective and a practice that we can choose for the rest of our lives. Eunice, I see that you're unmuted. Did you want to say something?
Yeah, I just wanted to bring up the fact that I'm an older woman, and a lot of the women or people that are supervising me now are extremely young. So this is one of the reasons why I decided to take up the course, because I find myself, although they have the degree, that they have to learn, I guess is the competence piece, so that they will know and stop assuming that I'm supposed to know certain things. They like to should on me a lot. And I'm like, I'm not comfortable with that. And, in my way, I have to teach them, coach them that, you have to, understand that I'm learning too. So, yeah, I like to bring that age up, the age range.
Yeah, I'm glad you did bring that up, because that is another area, and I think it's probably fair to say that that's also another area of cultural competence, because one has a different experience. One can be doing this work for many, 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 many years and end up with a supervisor who is brand new to the profession. And that's fine. But Eunice, as you were saying that, there was a phrase that really came to my mind. And if I were your supervisor, and I'm probably a number of years advanced than you are, but if I had the opportunity to be your supervisor, and there were a difference in our ages, my hope, just like what Dr. Holly and I discussed about cultural differences or racial differences, it would be important in terms of developing the supervisory alliance that we would talk about age and we'd talk about experience and how that could potentially, again, if it's avoided or ignored, it can damage the supervisory alliance.
Yeah.
Fantastic.
I agree. Thank you.
Yeah, and thank you for bringing that up. I'm just going to quickly check the chat. Yeah, okay, good. So a number of people are familiar with cultural humility. That's fantastic. All right. So folks, I do want us to have a little bit of time to look at this scenario and to get your sort of tips and takes on it. But again, these are a couple of additional bullets in terms of managing power and authority, which we've been talking about. And one of the things that I take away from this particular slide is supervisory alliance and conversation. That supervisors and supervisees do need to be able to talk with each other about these things in order to effectively sort of manage the fact that the supervisor has power. The supervisor, and Eunice, I'm thinking of your example, this person who maybe has less, quote unquote, experience than you do is authorized in their role to be your supervisor. And that does give them a certain amount of power. And as supervisors, we need to understand that that's a reality of the situation. And we can still collaborate and we can still work together in regard to that. Excellent. Thanks for letting me know, Juan. All right. So there are a number of slides in here that I extracted in my slide deck to make them a series of tips that all kind of follow each other as kind of quick shorthand. So again, this one's specifically focusing on regarding the relationship, the supervisory alliance. And you will have these in your complete slide deck that Juliana referred to earlier, but they're not lined up in the way that I've lined these up. I wanted to line them up so that you would have all the tips together and that you could look at them kind of as a combined set of tips. So when you manage your own slide deck, if you want to do it that way, or if you want to print them out individually, you're more than welcome to do that. I just wanted us to be able to look at them this way. And it does occur that there are times, and I know that a number of you alluded to this earlier in our conversations, there are times when there is conflict in the supervisor-supervisee alliance. And I guess as you look at these particular 6 bullets of, again, tips for managing conflict, these are very general tips. But as you look at these particular tips, the thing I'm going to ask you, and I'm asking you to do this rhetorically, because I do want us to get a chance to look at this particular scenario before we conclude today. But I'm going to ask you to think about this rhetorically. Is, of these 6 bullets, which ones of these do you think that you would find as the supervisor very easy to carry out? And which ones might you find more challenging to carry out? And again, I'm only asking you to look at them that way because as supervisors, as clinical supervisors, we're all, Maisel, I think you did get the slide deck, but if you didn't, we can definitely make it available to you so you have it. And then you can arrange it any way you want. So it's a useful tool for you. I'm pretty confident, though, all of these tools are also these tips are also in your workbook. But again, the reason I'm asking you to look at this in terms of managing conflict this way is because you're assessing, as you move toward and develop your own personal goal of clinical supervision, which hopefully is flexible and you're able to adjust, but you're looking at what are the things that I feel comfortable and at ease doing, and what are the things that would be growth opportunities for me, things that would be an opportunity for me to develop. And, you know, I'm thinking of this first bullet here, open and frank discussion. Conflict, we all have our own individual relationships with conflict. And as a supervisor, knowing our own experience, reaction, understanding to conflict can be really important because, again, depending on our own experience, an open and frank discussion about a conflict might feel very uncomfortable or very intimidating. So again, these can be really helpful things to look at. Where are my areas of growth potentially here? Yeah, and Zach, actually, thank you. I wasn't reading your mind, Zach, but yeah. So that one might be the most, and thanks for identifying that. So again, I'm asking you to do that rhetorically. Zach, thank you. Zachary, thank you for putting that in the chat. But I'm asking you to think about that from a rhetorical perspective. So this is a particular scenario, and I'm going to read this scenario out loud, and then I'm going to ask us to comment on it. And you'll see that it's in the participant workbook on page 32, if you would prefer to read it there and not hear me read it out loud. But a supervisee's former supervisor was highly critical, directive, and constantly disappointed in the supervisee's performance. Now, In a new supervisory relationship, the supervisee is hesitant, afraid of criticism, of taking risks, and of being observed. Even though the supervisee is achievement-oriented, there seems to be a strong fear of failure. The supervisor notices the resistance to supervision and is trying to communicate that making mistakes and taking risks are a natural part of the learning process. So I'm going to stop sharing my screen here. And I'm just going to invite thoughts or reactions. Well, let me ask this. Has anyone ever had this scenario occur in a where you got a new supervisee that Heather's like, no, where you got a new supervisee that had kind of came into supervision with this history about clinic? Juliana, yes. Anybody else had that scenario where, yeah, Zachary, yes. Anyone else? Yeah. Okay, Lourdes, yes.
No,
Okay.
I'm sorry. I have a reverse type. I'm
Okay.
reversed. In other words, yeah, I was the supervisee in the former.
And you had that experience.
Yes.
Got it. But again, we're looking at it from a supervisor. Before we go any further, let me just ask this, because Maisel writes, having one bad experience can truly traumatize you. Yes. Yes. And Maisel, I will throw out too, having one really great supervisory experience can also really make you excited about supervision. So both are Margaret's like, yes, but absolutely, both are true. So let me lay out the scenario one more time. We're the clinical supervisor. A supervisee comes to us. They have this history. And we notice a reticence or resistance to engaging in clinical supervision. So my question to you, because we're all putting our clinical supervisor hats on, my question to you, and maybe we can hear from three people, but my question to you is, as a clinical supervisor, what's your approach? What are you going to do? How are you going to address this? And we're just putting ideas on the table. So what do you think? And you're more than welcome to type in the chat or unmute. Margaret writes in the chat, meet to discuss supervision history. Yeah, and Juan writes, and I think very accurately so, starts with supervisory alliance. So Margaret, would it be okay if I asked you a follow-up question in regard to what you wrote in the chat?
Yeah.
So let's say I'm the supervisee and I walk into your office. So what would you say to me? How would you, if your goal was to bring this up, how would you go about it?
So again, this echoes with, my whole theme throughout my career, which is scalability of actual direct care to supervision. And I've had plenty of patients and clients who have been traumatized by earlier treatment, right?
Yeah.
Old treatment modalities were very abusive. So same thing here. I would sit down, I'd be like, I'm sensing a little bit of resistance and I want to understand where that comes from a little bit, call them in to have a discussion about it, and understand what it felt like and what that brought about in your supervisee, and what they were hoping for before they had that experience. That will give me an idea as to another one of my, I guess, personal administrative themes, which is to give someone a new experience. That's how you change that trauma and you get somebody to lower their resistance. So I know when clients sit in front of me, they see a white lady who is a boss, who, and anytime they've experienced somebody who has power over their treatment, who looks like me, it can be, they feel very much not empowered. They feel very weak. They feel like they don't have a say. They feel like, this white savior kind of thing coming in. So I know that from the get-go, considering the population that I treat. And when they come and sit in front of me, I absolutely approach from a completely different perspective. I lead with yes, I lead with trust, and so when somebody, I didn't do that. All right, I believe you. So you have to give them that different experience that completely opposes the last. So
Understood.
Yeah.
So that's an excellent description of your approach. Excellent. So what I want to ask, and maybe I can ask Eunice this. Eunice, you wrote, and this is very similar to what Margaret described, you wrote explore the history and expectations for this new relationship. So if I come and I sit down in your office and you know that this is the case, that this is what I'm coming to this moment with, how are you going to begin that conversation? What are you going to say?
Well, it's the greeting, and then I want to do the small talk as far as exploring the last relationship they had, and if they had any, anything they would like to talk about that maybe they don't want me to do what the last person did, and basically just validate where they are with that, and then begin to just move forward as far as what are your expectations and what would you like to see here, and allow them to share that what they would like, and we can write down those goals and allow them to know that that would be something that we can work on.
Okay, excellent. Thank you, Eunice. And again, a really good description of it. So, and Juliana writes, tell me what has been helpful and what has been unhelpful in past supervision. Yeah, and to put like a practice tag on that, excellent open-ended question that invites the person to elaborate. But I want to throw out something to consider here. And then we'll pause in just a couple of more minutes. In like 5 minutes, we'll pause to reflect on today. But I want to throw out something here. We'll never get to the open-ended question, which again, wonderful. Juliana offered an excellent open-ended question. A number of people are describing, how we would create a different experience. The thing I want to underline, though, and again, this is part of what clinical supervision is, and I really want to underline this, is engagement. So we'll never get to that open-ended question unless everything that comes before that open-ended question creates an opportunity for engagement with this particular supervisee. So my question to you, we know that that's the area that we're going to go to. We know we may invite this person to talk about their past experience. But how do we build the engagement with this particular person? How do we build that engagement? What would you do in order to do that? And you can unmute or you can type it in the chat, whatever. How would you do that? Buy them a burrito. I don't know about that, but I like the sound of it, given that, it could be wherever we may be. It could be getting near lunchtime. And how would you build, how do you build trust? How do you build trust? Yeah, go ahead, Trisha.
I know for myself,
that takes time, Deborah says. Yeah, go ahead.
I know that it takes time to build that trust, but I try and meet them where they are at, per se. Meet that person where they are at, ask them open-ended questions about themselves. How do they feel about it? Validating concerns and moving forward, what are their expectations?
Yeah.
So you know.
Yeah. Fantastic. Fantastic. So building trust takes time. Getting a sense of where the person is, self-disclosure, Juliana, possibly. Self-disclosure might be absolutely appropriate in this situation. Through modeling, Charles mentions, and trust takes time to build. So I want to underline trust takes time to build. Several of you have said it. And Beretta mentions provide a safe and trusting environment. Agree being, yeah, they're excellent. So they're all coming in. So what I want to underline in terms of what Charles and others said is it's probably not effective and inappropriate to assume that this supervisee is going to trust us simply because we're their supervisor. So we have to let them get to know us as we get to know them. And we hopefully will demonstrate an environment that is respectful, attentive to their needs. And by communicating that, we then may get to, you know, as we build our supervisory relationship, would you be willing to tell me a little bit about what your experience of supervision prior to our being together was? It might help me to understand. And attentively listening that, inviting that. Yeah, and Alexine says that she might say a little bit about her which would be, again, the self-disclosure piece. Fantastic. So what I'm going to suggest, you know what I'm asking you to prepare for next time.
Can you repeat that?
Which part?
The part where we need to prepare for next time.
Yes, and it's a two-parter. So part one is you identified as a clinical supervisor a particular strength. And I'm going to ask you to look at 21A, and I'm very clear it's 21A, not to confuse it with any other number or letter. 21A, to see if there's a competency listed there that speaks to the strength, the growth opportunity that you want to focus on. So that's part one. And then part two is I want you to be thinking a little bit more about how we would address this particular scenario. Like what we would do in the conversation, in addition to everything we've talked about, trust takes time, possible self-disclosure, all of those things. But any other thoughts that come to you until we see each other tomorrow at 12 p.m. to 3 p.m. What other approaches or thoughts you may have about how you would address this particular situation where a supervisee has had a very negative, I'll go so far as to say possibly traumatic experience from a prior supervisory or maybe several supervisory experiences. And it's really impacted how they go forward. So part one, 21A, your particular growth opportunity. Part two, any other reflections or thoughts about how you would, from a clinical supervisor's perspective, approach this scenario. So that's part one. Part two, any other thoughts or reflections about this particular scenario? All right. So folks, in the last moment or two that we have, actually we don't have the moment or two. What I'm going to ask everybody to do is I'm going to ask you to pick one word that describes your experience of part two of our conversation about clinical supervision within our learning community. One word, there's no right or wrong. It's just whatever word describes your experience. One word, and just type it in the chat. It's one word. It's neither right nor wrong. It's just your one word. And once you've typed that word into the chat, once it's clarified for you, we are complete for the day, and I'll look forward to seeing you tomorrow at 12. So one word. And take a moment, if you can, to read other people's writing. I want to thank everybody for what you brought to the table today. And again, I'm looking forward to seeing you tomorrow.
See you tomorrow.